which are the clinical messages coming from SHARP that you are leading in this period?
Well, it's early days for SHARP. So we have had a series of meetings. The most important meeting was the one we had in Zurich in this spring, and we had, in SHARP, we have 4 stakeholder groups. So we have patients are one group, then national leads are another group, then we have scientists, then we have pharmaceutical colleagues. And all of these 4 groups, we've had a number of telephone conferences and a number of, in fact, probably around 30 questions came out of those discussions. And how, what do you do with so many questions? What we then decided was to create working groups. And so we have 7 working groups. I don't want to list them all, but and the first question, of course, that's the most urgent one, is how much variability is there in asthma, in clinical asthma, in the asthma phenotypes across Europe? That's the first question. And how do we, in order to do that, to address that question, we need registries, and we very much count on the SANI registry to feed a lot of information into that. The second is to understand how it is that, what is it that patients want? We talk about patient-reported outcomes, so breathlessness, we have the ACQ, we have the asthma questionnaires and so on. And the first thing that we heard from patients was that they have additional questions, things like fatigue, like depression, like anxiety, which we don't necessarily bring into. And so there came a very interesting interaction between scientists and patients, where the scientists said, shouldn't we understand the mechanisms that are responsible for the patient-reported outcomes, for how patients feel? And then maybe we should develop drugs for this. So the 4 main objectives of SHARP are to completely do away with the need for oral steroids. Yeah. So that means having no more exacerbations. Second, that all patients across Europe have access to experts like us, because at the moment I'm sure that's not the case. Then we want to understand the mechanisms that underlie the different phenotypes. And fourth, and very ambitious, is to stop progression of moderate forms of asthma into severe asthma. Quite an ambition.
Yes, I think it's
quite an ambition.
And one of the main problem, I think that it's very important to share the opinion of the patient and the opinion and the study of the scientists, of course, because sometimes we are focused, for example, on biomarker. We are focused on the effect of biologics, but the life of the patient is completely different, of course. One of the main problems in our daily life is that the neutrophil phenotype is something not well defined, because eosinophil phenotypes is a patient with severe asthma is lacking, if he has the eosinophilic phenotype, because there are a lot of possibilities to treat. What do you think about the other phenotypes? Because there are different opinions, there are different treatments, and I think that it seems that neutrophil is what the neutrophilic asthma is what is not eosinophilic asthma, but it's not true. Because there are many different sub-phenotypes, I suppose.
I think you're right. First of all, we are very fortunate that for eosinophilic asthma, you're right. If you have eosinophilic asthma, then there's a chance for you. But let's not forget that 40% do not respond, and that's a big question. If you are one of the 40%, then you are disappointed. But I agree with you. The neutrophilic form is a real mystery, and I'll be honest with you, we simply don't know enough about the mechanism. There are hypotheses being discussed as we speak, not least, for example, interleukin-17 as a driver of neutrophilia, and then issues like the microbiome is different in neutrophilic asthma compared to the eosinophilic one. But that's not much, is it? We don't really understand. But I would add to this another big phenotype, which is the paucigranulocytic. There are not enough. There are lower numbers of both neutrophils and eosinophils, and that is a real enigma. Why do they? It's almost like a different disease altogether. There's no inflammation, so there's plenty to do. Now, to come back to SANI and to SHARP, we can understand these phenotypes only if we work together. You cannot study this in small, let's say you in Verona or we in Southampton. How many patients do we have? What means do we have? We don't. So we have to come together and have enough patients so that you can really look at the detailed mechanisms.
Now we are collecting a very high number of the centers. However, my feeling is that it's sometimes difficult to combine a very high profile of the center and the high number of the center. Because of course, for example, some techniques, some exams are carried out just in the top level centers and are not possible or in others. So how is it possible to overcome this situation? Because I think that we have to collect many centers in order at least to collect many information.
Yeah.
However, I think that these patients are not. It's not possible to study them at the same level.
Well, I guess you are right. I say I guess because I don't know. I don't work in Italy and I don't know what the local difficulties are. But to get induced sputum is not terribly difficult. I think it should be possible in a regional hospital, as long as there's enthusiasm, and of course there needs to be funding. So maybe the problem is that big hospitals, big university centers have more money, and therefore maybe that's the problem. But let's assume that what you say is right, and so you have a Premier League, of centers who can
speak about food, but it's okay.
Yeah, so that do extremely well, and then you have some
championship.
The championship.
Okay.
Now, there are things that we can all do relatively easily, So urine is turning out to be very, very informative. And not just, for the standard eicosanoids, but also for, the metabolome in urine. I think there's a lot to be done with urine. And there's nothing easier to collect urine. Very easy. Then blood. The blood gives us a lot of information about the sort of systemic components of asthma. It doesn't necessarily completely reflect what's happening in the airways, not as well as, for example, sputum, but it gives you good information about the systemic component. And it's very good for longitudinal follow-up. It's very good for interventional studies. It's very good for comparison across different ages. So, for example, in the UBIPRA program, we've been looking now more recently at the transcriptome in blood between children and adults. It's fascinating. The differences. You wouldn't have thought that the differences are so enormous. And then, perhaps the most exciting of all is the breath, exhale breath. So that can be done. There's no excuse for any center not being able to use exhale breath. Especially, if I may say, there are now methods being developed where the sampler is connected to a spirometer. So you don't need to blow into a specific, container and then put it in the pulse and so on. No, the sensors, the analytical part of is part of the in sequence with the spirometer. And then the information goes up into the web and comes back, so you get almost an instantaneous analysis of the breath. And we're seeing every day fascinating data showing how, for example, you have a breath signature that is predictive of a response to a biologic. Or most recently, and this is not published, I've seen some data from Peter Sturck, where there's, I don't know if you recall, but UBIPRA produced these transcriptome-based clusters, TAC1, TAC2, TAC3, published in the European Respiratory Journal. And they've identified breath signatures that can predict very, very highly, with high certainty, can predict the 3 TAC endotypes. So that's fantastic. So I think, and this is something that I will encourage every national society to do, is to create as good an infrastructure as possible, and to be as inclusive and as supportive of smaller centers, so that, because this benefits everyone.
So it's a matter of organization
and money.
That's a problem in Italy.
It's a problem. Yes, it's a problem everywhere.
I think. Yeah.